Good morning. Welcome to Department of Medicine Grand Rounds. It's really a pleasure for me to introduce our Grand Rounds speaker. Keeping in the tradition of giving the Chief Residents the opportunity, which they begged for, to give Grand Rounds, Andrew Vreede is our speaker today. Andrew grew up in Ann Arbor. He graduated from Kenyon College with high honors in Phi Beta Kappa. He thought he was going to be a PhD scientist and went off the NIH and did neuroscience research for 2 years working with the fruit fly. He then went on to 1 year as a research technician at Ann Arbor before he started medical school, and he graduated from the University of Michigan Medical School. We were delighted when we recruited Andrew to be an intern and resident and then subsequently chief resident in our residency program. And this summer he's off back across the lake to Ann Arbor to become a rheumatology fellow at the University of Michigan. Along the way, Andrew has published 6 peer-reviewed journal articles. He's got another that is being prepared. He has a number of outside activities, more standard medical activities. He's volunteered for Medic Grace Clinic, and he's been a teacher in Patient Doctor and Society. More interesting, perhaps, is he was part of the NIH Orchestra and Brass Ensemble and has been a member of the Madison Community Orchestra playing the trombone. He's earned a number of honors. Among them, in 2013, he won first prize for the clinical vignette poster competition at the ACP Wisconsin chapter. I've really enjoyed working with Andrew and all of the chief residents this year. I painfully regret that I will miss Lindsay Voss's talk. I'll be in the south of France at a meeting. But universally, not to put any pressure on Andrew, whose parents are actually here, and we're glad to welcome them, but not to put any pressure on Andrew, but consistently these have been among the best Grand Rounds that we have. And Andrew, you couldn't be giving Grand Rounds before a more supportive audience. So with that, Dr. Vreede's talk is entitled Delayed Recognition of Spondyloarthritis, Diagnostic Challenges and Opportunities. Please join me in welcoming Dr. Vreede.
Thank you, Dr. Page, for that very kind introduction. It is an honor and a little nerve-wracking to be able to stand here today to talk to you about a topic that, admittedly, I'm not an expert in at this course of my training, but a topic that I developed a really strong interest in as a result of my experiences during residency. The topic that I want to talk about today is diagnosis. As my dream speaker, Dr. Dhaliwal, mentioned in his Grand Rounds, diagnosis is arguably the foundation of medicine. Without a diagnosis, one cannot provide explanation to a patient that's suffering. Without a diagnosis, one cannot provide an appropriate treatment. What I want to talk about today and explore is when diagnosis is delayed. Why does this occur, and what can we do about it? These are the questions that we'll explore today during the course of this presentation. I developed an interest in this as a result of my experiences working in the clinic of Dr. Kevin McCown during my second and third year of my subspecialty continuity clinic. And during that clinic, we were asked to consult on a patient not too different from what you see here, a 40-year-old woman with several-month history of back pain that's not improved with conservative therapy. And the question that was posed to me was deceptively simple. Does this patient have inflammatory back pain? And as it turns out, this is a really difficult question that has been the course of study for over a half century. We'll explore this difficulty as we follow the course of this patient during this presentation. One of the really interesting and shocking things about this field is that there's a very long delay in diagnosing these patients, shockingly long delay. This figure displays the age at first onset of symptoms, as represented by the circles, as well as the age of at first diagnosis, as represented by the triangles for each given age. And as you can see, there's approximately an 8 to 10 year delay before these patients are finally diagnosed, with a slightly increased delay in women. And if you take a step back, if you take a step back, diagnostic delay and error is now being recognized as a major cause of patient harm in the patient safety movement. We in fact had a few grand rounds speakers in the last few years that discussed this topic in greater detail, including Dr. Dollawall, Dr. Graber, Dr. Wachter. And these are a few headlines from the Washington Post commenting on this. As a result of the increasing attention from the medical community, as well as the general public, the Institute of Medicine just released a report in the latter part of last year, Improving Diagnosis in Healthcare. This is considered to be the missing chapter from that original 1999 report to Err is Human, which, as you know, helped broker in the patient safety movement. One of the reasons why, even though we knew that diagnostic error was a huge part of patient harm, that this has not been studied more carefully until recently, is that we just didn't have a way to measure it from a lack of a standard definition. The Institute of Medicine helped with this by standardizing this definition here, this failure to establish an accurate and timely explanation of the patient's health problems or communicate that explanation to the patient. And as part of that report, they developed this schematic demonstrating the processes involved in the diagnostic process in an effort to try to understand where are we failing in this process. So in a completely idealized scenario, a patient will experience a health problem, engage with the healthcare system, and then at that point there's this complex interaction between the provider and the patient, in which information is being gathered by history and physical, information is being integrated and interpreted, and a working diagnosis is created. This diagnosis is then communicated to the patient and a treatment ensues. But as you know, in the real world, in the busy clinic environment, causes of error and delay can occur throughout this process. And I just put a few up here. There could be errors in the information gathering stage, perhaps just the provider and the patient just doesn't gel, and we're not able to get a good dialogue. Perhaps the provider fails to obtain all available info. There's errors within the information integration stage. For example, cognitive biases are bound, and there's a long, long list of different cognitive biases that can affect us. But it becomes even more complicated. There's different sources of error that comes from the patient. Perhaps just the patient's just not able to communicate their symptoms well to the provider in a way that the provider can make sense of in a medical way. And perhaps there's sources of error from the provider. Perhaps the provider is just distracted from the last patient they just saw. Perhaps they're still thinking about that patient with the atypical chest pain, amongst having multiple patients waiting to be seeing them in clinic. For back pain, it becomes even harder. So differentiating inflammatory from mechanical back pain, which is the purpose of my talk, is incredibly difficult. And it's difficult for a number of different reasons. For starters, we just have a really poor understanding of the underlying diseases of mechanical back pain and inflammatory back pain. For example, 85% of patients with back pain do not get a pathoanatomic diagnosis. Instead, they just have a diagnosis of back strain, low back pain. The back joint is not easily visible. So in contrast to the knee or the wrist, where you can easily see if the joint is inflamed and swollen, we just do not have that luxury in the back. There are a number of different clinical features that have been developed over the years to try to identify these patients. However, none of them are 100%. Further, diagnostic studies are also not 100% in trying to differentiate these patients. Finally, the few diagnostic studies that we actually have are cumbersome and expensive. Thus, we cannot roll it out to every single patient that presents with back pain. Finally, the gold standard diagnosis is just based upon expert opinion. We don't have that biopsy result that says, yes, this patient definitely has inflammatory back pain. So the goal of my talk is a practical one. I want to explore the causes and solutions for this diagnostic delay. And in the process, I want to improve the awareness and understanding of the ability to identify patients with spondyloarthritis at an early age. While at first glance these patients may not be easy to identify, it might be difficult to differentiate from the larger pool of patients with mechanical back pain. By the end of the talk, hopefully these patients begin to stand out. So before we go into the causes, and I also want to emphasize, however, that this is a problem that is not unique to the detection of spondyloarthritis. This is a similar problem as detecting any relatively common diagnosis that is not the most common cause of a presentation. For example, celiac disease also has a diagnostic delay of 10 years within gastroenterology. So hopefully some of the lessons that we learned today can be expanded and extrapolated out to other problems. So before I go into the different causes and solutions for diagnostic delay in back pain, why even a topic in back pain? I admit that this is not the most exciting topic to be providing in a grand rounds environment, but I would argue that it actually is a pretty exciting topic. For starters, as you know, low back pain is an incredibly common problem. You will see many patients with back pain in the course of your busy clinical practice. So as a result, it makes sense to have a system in place to work through these patients and identify the ones that have inflammatory back pain. So the lifetime prevalence of experiencing back pain is approximately 80%. So 80% of the people in this room will develop back pain at some point in their life. Further, the point prevalence of experiencing back pain is about 20%, which is about the prevalence of chronic low back pain in the United States. And these patients see their physician. So this is the survey looking at the number one reasons for the patient seeing the provider in 2012. And if you can see, the number 3 and number 4 cause here is low back symptoms and back symptoms. And if you add those two together, they're at or near the top of the list for patients seeing their physician. If this was a really, really rare condition, there would probably be less reason to be talking about this topic during a grand round setting. However, based upon new advancements in disease understanding, spondyloarthritis is now considered by the most recent NHAIDS data to be at approximately 0.9 to 1.4% of the U.S. population, representing 1.7 to 2.7 million Americans. And just to put this number into context, this is roughly the prevalence of rheumatoid arthritis in the U.S. population. Why does this matter? Well, these patients do suffer as well. This is a table that looks at work disability rates for ankylosing spondylitis patients, which is the prototype disease of an axial spondyloarthritis, compared to the general population. And what you can see is that the rates of work disability for these patients are roughly 3 to 5 times that of the general population. And finally, why this is really important is that we actually have treatments for these patients now. Unlike the patients with more mechanical back pain, where admittedly our treatments are not that great, given the fact that the number one class of medication for patients with mechanical back pain is opiates. Patients with inflammatory back pain have treatment options. Number 1, physical therapy for all patients. Number 2, inflammatory dosing NSAIDs. And if inflammatory dosing NSAIDs do not work, then TNF inhibitors. This is a graph looking at the number of patients that respond with a functional and pain outcome, the ASAS 20, in a measurable, significant way. And as you can see, about 60% of patients respond to any given TNF inhibitor. So what are the causes of delayed diagnosis? Well, if we go back to that Institute of Medicine diagnostic process schematic, the first potential cause of delay is just that the patient fails to engage with the healthcare system. Perhaps they're experiencing back pain, but they just don't go and see their doctor. So is this occurring for patients with spondyloarthritis? Well, this was actually a very interesting study that was released in 2014 that examined the effect of a 6-week ankylosing spondylitis public awareness campaign in New Zealand. And it featured a popular race car driver with ankylosing spondylitis. And it looked at the number of referrals before this public service announcement and after, over a 3-month period before and after. And what you can see is that the number of referrals and diagnoses approximately doubled as a result of this campaign, suggesting that there is, in fact, a significant delay as a result of patients just not engaging with the healthcare system. Going back to the diagnostic process, if you look at the overall diagnostic error literature, it suggests that the majority of diagnostic error occurs during that complex stage, that stage between the patient and provider, where many things that I mentioned can go wrong. Is this what's occurring for patients with spondyloarthritis? Well, this was an interesting study in the late 1990s. And researchers in this study were studying the prevalence of spondyloarthritis in a really small, stable, homogeneous population, the Alaskan Native population. And the benefit of this is that they were able to identify all potential cases of patients with spondyloarthritis, and they were able to do that through chart review, word of mouth, just finding every potential case. And what they then did is that they had the benefit of having EMR going for the last 20 or 30 years before that, and they were able to say how many of these patients were actually diagnosed before we identified them during this intensive study. And what you can see is that only 30% of patients were previously diagnosed with spondyloarthritis that indeed had a diagnosis of spondyloarthritis. Put it another way, and 70% of patients in this population were undiagnosed at the time of the study. This was particularly the case and jarring for women, where only about one woman in the entire population was diagnosed with spondyloarthritis, and the vast majority of them were undiagnosed. This was not a case of the patients just failing to engage with the healthcare system. All of these patients had seen their doctor, and they were given a plethora of different diagnoses. What you can see here is that, number one, there's just many different diagnoses provided to these patients, and number two, a lot of these diagnoses are just very general and lack that pathoanatomic diagnosis that I mentioned earlier, such as low back strain. So what the study tells us is that there's some point during that doctor-patient relationship where the diagnosis is just not made. And is it due to just information gathering problems or information integration problems? We just can't say from this study. For that, we need some other qualitative studies where we directly talk to physicians and ask them what they think. And that's what I'll be showing here. So this was a study that talked to 10 different GPs, and they asked them about their knowledge and understanding of ankylosing spondylitis. And interestingly enough, 10 out of 10 of them said that they knew exactly what, and it could accurately describe classic ankylosing spondylitis. They could describe that rigid bamboo spine, pain at night, that we all know of from the test questions. But all of them felt that it was exclusively seen in men, so perhaps that's misconception is playing a part in the fact that women are not being diagnosed. And all of the GPs were not confident in differentiating mechanical back pain from inflammatory type back pain, which we'll explore later during this presentation. Further, the majority of the GPs were not aware of the extended spectrum of disease of spondyloarthritis, all the peripheral articular manifestations as well as the other disease associations, which are also very helpful in differentiating these patients. Given the fact that there are these misconceptions out there, I thought it'd be worth to kind of go through a little bit of a refresher of what spondyloarthritis is in this case. So just as a refresher, the spondyloarthritis are a family of unique conditions that all share many features together. They share a common clinical phenotype. They share genetic associations, particularly with HLA-B27, and they share the fact that they do not have rheumatoid factor positivity. They all share the spectrum of disease in which some of them have more axial predominant symptoms, or meaning skeletal spine, or they have more peripheral articular manifestations. The diseases that are predominantly axial are ankylosing spondylitis and undifferentiated spondyloarthritis. The diseases that are predominantly peripheral are more the psoriatic arthritis, inflammatory bowel disease-associated spondyloarthritis, and reactive arthritis. Even though the patients with a psoriatic arthritis may, as a group, be more peripheral predominant, that doesn't mean that these patients cannot present instead with an axial spondyloarthritis. So all of these patients may present with a spine spondyloarthritis. One of the really helpful differentiating features to identify patients with spondyloarthritis from mechanical back pain is the epidemiology of this disease. So, interestingly enough, this is a disease of the young people. and therefore 95% of patients will present before the age of 45. We can use this to our advantage. If a patient's presenting with back pain at age 50, it's unlikely that this patient will have spondyloarthritis. However, if the patient's presenting at the age 30, 35, 40, then it needs to be higher up on our list of consideration. One of the really early historical features that helped us differentiate patients with inflammatory back pain is this inflammatory type back pain phenotype. And I think a lot of us kind of have the general idea of what this is. This was originally developed in the 1970s by Kalin in a 2-page JAMA article. And since then, it's undergone a number of different iterations, but it's basically the same as what you see here. And according to this criteria, you need inflammatory type back pain is improvement with exercise, pain at night, with improvement upon getting up, insidious onset, age of onset less than 40 years old, and no improvement with rest. The early studies showed excellent differentiating ability of inflammatory type back pain. Later studies, a little bit more modest ability to differentiate these patients, which I'll show a little bit later. Some of the peripheral articular manifestations, dactylitis, particularly that we think of with the sausage digit of psoriatic arthritis. There are also, strangely enough, all these extra-articular manifestations. One of the more helpful differentiating features is uveitis, which is a red, painful eye with photophobia. There's enthesitis in the spectrum of spondyloarthritis for whatever reason, or inflammation of the tendon inserting into the bone. Particularly, this is of the Achilles tendon. However, it can also involve the plantar fascia and the atypical chest pain patient in the costochondral joint. One of the more rare, although well-described manifestations is cardiac manifestations. For example, patients with low aortic insufficiency are found to have a very high association with spondyloarthritis, as well as cardiac conduction deficits. And what I really want to point out here is that the clinical manifestations means that these patients are going to be seeing many different providers. They're not just going to be seeing their GPs for back pain. They're going to be seeing their gastroenterologist for IBD. They're going to be seeing the dermatologist for psoriatic arthritis, ophthalmologist for uveitis. The list goes on. In the 1970s, HLA-B27 was noted to have a high association with ankylosing spondylitis. And I would like to spend a few minutes just reviewing one of the early studies looking at HLA-B27 and ankylosing spondylitis, as I think it helped confront a couple myths that we continue to battle with today. In this study, in the 1975, they had 2,400 healthy blood donors that donated their blood to Stanford University. These patients had no diagnoses, no symptoms, completely healthy. And from this sample, they were able to identify 120 patients with HLA-B27, which is about what the U.S. prevalence of HLA-B27 is, 6% of the U.S. population, as well as 190 HLA-B27 negative controls. They were able to locate the majority of them, and then of the patients that they were able to locate, they sent them a health survey, basically past medical history, medications, current symptoms, family history. You get the idea. And this, as it's been a number of years since they donated the blood, some of them have actually maybe developed some symptoms. And what they found was really surprising. Of the 78 patients with HLA-B27, 30% of them had active back pain at the time that they returned the survey, compared to 9% of the patients that are controls. And this back pain wasn't just a mild strain back pain. These were back pain severe enough for them to see their physician, and severe enough to receive an x-ray. And interestingly, even though all of these patients had an x-ray done looking for some type of pathology, none of these patients ever received a diagnosis of ankylosing spondylitis. But when they took a retrospective look at these x-rays from the ones that they were able to obtain, 17% of the original sample, or 13 of the 19 that had the x-ray, had definite ankylosing spondylitis. So, this is the penetrance, according to this study, of ankylosing spondylitis and HLA-B27 positivity. was 17%. This is a slight overestimation of what we currently believe the penetrance to be, which is a little bit closer to 8%, 7-8%. But it still shows just the high penetrance of disease in HLA-B27. One of the myths that existed before was that this is an incredibly rare disease. 0.15% of men and 0.015% of women would have ankylosing spondylitis. And what they found was that the patients with ankylosing spondylitis were actually half of them were men and half of them were women. And with a few back-of-the-envelope calculations, 17% of the HLA-B27 patients having ankylosing spondylitis and 6% of HLA-B27 in the United States, their actual estimated ankylosing spondylitis prevalence was closer to 1%, showing that our prior prevalence data was much lower than what was actually probably more likely the case. What they also saw as a myth was that this disease just does not happen in women. And this is something that we're still continuing to try to confront today, this myth. And interestingly enough, since that original studies that were done that showed a ratio of 10 men to 1 woman diagnosed with ankylosing spondylitis, since that point, the studies have just continued to show a ratio closer and closer to about 1-to-1 ratio between men and women with this disease. There was also concern in the rheumatology community that the patients that were the only patients that were being diagnosed with ankylosing spondylitis satisfied the classification criteria, and that the classification criteria had a pretty poor sensitivity. You might remember this from medical school, but the classification criteria for ankylosing spondylitis involves having at least one of 3 clinical criteria: inflammatory tight back pain, or limitations in the spine or chest expansion, and has to have radiologic abnormalities, the SACROILIITIS that you can see here, showing by the enhancement around the sacroiliac joint. But when you take a look at studies in which you have patients that are very suspicious for having spondyloarthritis, whether it be due to a family history or some of those clinical manifestations that I mentioned earlier, and you look at how long they've had the disease and how many of them actually fit this criteria, particularly with the radiologic changes, if the patients have only had disease for less than 2 years, none of them fit the criteria for having ankylosing spondylitis. And every 2 years, there's approximately 5 to 10% more patients that begin to satisfy the criteria based upon now having the radiologic changes. And it takes over 10 years to finally develop those radiologic manifestations. So perhaps that 10-year delay in diagnosing these patients is due in part to just the disease natural history just taking 10 years to satisfy the way we diagnose these patients. And it makes sense. 3 of the 4 things within that criteria really take time for them to manifest. Those are listed here in the red. So limitations of your spine or chest expansion require ongoing damage. The radiologic changes take time as well. We often think of this with osteomyelitis, that it takes time for the radiologic manifestations to show themselves, whereas MRI or something may pick it up earlier. So at that point in the 90s, we were taking an active look for other tools that might identify these patients. MRI was one of those tools that was actively looked at. This is one of the very early studies looking at MRI and whether they're able to pick up on these suspicious patients, but patients that didn't have those radiologic findings to make the definite diagnosis. And this was a very optimistic study, but it showed that clinically suspected patients, 100% of them had MRI changes, whereas patients with definite mechanical back pain, as determined by the researchers, none of them had evidence of inflammation on the MRI. Recent studies as well are a little bit less sanguine about MRI detecting these patients, but the truth is that MRI is very good at differentiating patients with those early manifestations of spondyloarthritis. And this produced this kind of paradigm shift in which we kind of started thinking that there's this pre-radiographic stage, and you require ongoing inflammation and time for the patients to finally develop the more overt radiologic changes that we were previously recognizing as the disease. Put another way, it's a little bit like the iceberg. We've always had those patients that we were able to identify with ankylosing spondylitis, the more classic case, the patients with the radiologic changes on X-ray. But there's this now subgroup, this more nebulous group beneath the surface, which they might have some inflammatory type features, but we weren't able to make the diagnosis with X-ray and instead require additional diagnostic testing to identify them. What is also worth noting is that we don't have a good idea of how many patients are out there with this. We have a pretty good estimate that the prevalence of ankylosing spondylitis, or those radiologic changes with inflammatory type back pain, is about 0.5% of the U.S. population. And our current estimates are that the non-radiographic patients are about 0.5% as well, but we just don't really know. Because as you can imagine, doing MRI on everybody with back pain in a study would be incredibly expensive and difficult. So going back to this patient, now that we kind of know the full spectrum of disease with spondyloarthritis and asked the patient about the different features, the patient endorses an inflammatory type back pain that satisfied that criteria that I mentioned, as well as having uveitis. The physical exam was unremarkable. So at this point, the question is this history sufficient for diagnosis? Can we just put this patient now on a TNF inhibitor, or at least inflammatory dosing NSAIDs? Or should we do additional diagnostic testing? And to answer this question, we use Bayes' theorem, everybody's favorite. And just to remind everybody, Bayes' theorem is the mathematical rule that explains how existing beliefs change in light of new evidence. So put another way, we have a probability of disease, and then we have a diagnostic test, and based upon this diagnostic test, we're then able to have a revised probability of disease. And the probability of disease before the test, we often estimate based upon the prevalence of patients. So in this case, what is the prevalence of spondyloarthritis in patients presenting to their primary care physician with back pain? And the diagnostic test is often reflected by the likelihood ratio, the percentage of the sick with the test result over the percentage of well with the test result. And I know this is where it becomes really dry and very academic, but this is something that we actually use every day in hospital medicine. For example, patients that we're trying to rule in or rule out PE. We use the Wells criteria to determine what's the pre-test probability of this patient having a PE. We use the abilities of the diagnostic tests to say how good are we able to differentiate these patients, such as D-dimer having a relatively low positive likelihood ratio and CT angio having a relatively high likelihood ratio. And then based upon that, then we can say, yes, this patient has a PE, or no, we have to look for alternative explanations for this dyspnea. So going back to back pain, we have very few studies that actually look at what prevalence is in the primary care clinic for patients presenting with back pain and how many of them actually have spondyloarthritis. This is our best study and the one that's cited routinely in the literature. And in this study, in the primary care setting, they had 313 patients between 18 and 60 years old, and they identified with undiagnosed chronic low back pain. And then of those patients, 15% of them had that inflammatory type back pain. And about 6% of the original group had one or more feature of spondyloarthritis. This wasn't the greatest study of it. They were mainly going based upon those clinical manifestations that we think of as spondyloarthritis, like enthesitis and that type of thing. They were not using the objective studies that we typically think of, like HLA-B27 or MRI. So we don't even know if this is exactly right, this pretest probability, but it's the best thing that we have. And then this is a meta-analysis looking at how good our diagnostic findings are in differentiating patients with inflammatory back pain from mechanical back pain. And this is a table that ranks it based upon highest likelihood ratio down to lowest likelihood ratio. And what you can see is that HLA-B27 and MRI are two really objective studies have equal positive likelihood ratio at 9. So quite good at differentiating patients with inflammatory back pain from mechanical back pain. What you next see is that patients with uveitis is the criteria that's highest within the clinical criteria at 7.3, quite good at differentiating patients with inflammatory back pain from mechanical back pain. What I'd also like to point out is that inflammatory type back pain, which I think is often just thought of as the only criteria for spondyloarthritis, the sensitivity of that is 75% and the specificity is 76%, with a rather, as a result, moderate to low distinguishing ability to differentiate these patients. The benefit of it is that the sensitivity is the highest of all these clinical criteria and is able to pick out the most of them. But what should be noted with that 75% sensitivity is that 25% of patients with spondyloarthritis will just not have an inflammatory type back pain. And put another way, with the specificity, 24% of patients with mechanical back pain will have an inflammatory type back pain picture, thus showing how complicated this becomes. How do we use these likelihood ratios and pretest probability? This is where we go to normograms. And so what we have is our pretest probability of this patient that was presenting to us in clinic of approximately 5%. And she has inflammatory type back pain, which has a likelihood ratio of 3. And so what we do is we can draw a line from 5% through the 3 in the likelihood ratio, and then we have a revised post-test probability that of disease at 12%. So she has now, just looking at inflammatory type back pain, she has a 12% likelihood of having spondyloarthritis. And then if we do this in tandem with other independent diagnostic features, such as uveitis, then we can start at the pretest probability of 12% that we ended with the last normogram, and go through the likelihood ratio of 7, and then we have a post-test probability at that point of approximately 50% that this patient has spondyloarthritis. So at this point, when she's seeing you, based upon your history and physical, she's a coin flip of whether she has inflammatory type back pain or mechanical back pain. So this is the point when objective studies are really helpful at distinguishing these patients, because we cannot just put patients with a 50% probability of disease on a TNF inhibitor. So if she gets either an HLA-B27 or MRI, and if it's positive, then she goes from that 50% pretest probability to greater than 90% chance of having disease. And at this point, then we start thinking maybe we should be putting her on treatment. And if the HLA-B27 or MRI is negative, then we can put the line through that 0.1 likelihood ratio, and she has probability of disease less than 10%. So at this point, we should really start considering other diagnoses, such as mechanical back pain. Obviously, we cannot do this for every single patient in clinic, tracing out the normograms in front of them. So at that point, algorithms were developed to try to diagnose these patients. And this is the modification of the Berlin algorithm for diagnosing axial spondyloarthritis. And what you can see with this algorithm is that if you have chronic low back pain, then according to the algorithm, then you get an X-ray, and if it's positive, then you have ankylosing spondylitis and your job is done. But if the X-ray is negative, that's when we have that complicated task of going through the entire history and physical, trying to get all those spondyloarthritis features. And then based upon the number of features, then we have a variable degree of post-test probability of disease. If you have greater than 4 spondyloarthritis features, then it's considered that our post-test probability is greater than 80%, and the patient likely has the disease. And according to this algorithm at least, no objective studies are needed to make the diagnosis. The other path, if the patient has 0 to 1 spondyloarthritis features, then the probability of her having disease is, like I said, somewhere between 5 and 12%. And that's when we're going to need additional and likely 2 objective studies to really get us above 80 or 90% post-test probability of having disease. If you're in the more intermediate range of spondyloarthritis features, then theoretically all you need is 1 objective study to make the diagnosis and have a high likelihood of disease. How does this actually work when it's validated in a cohort of patients? Well, it does reasonably well. However, there are patients that are missed with this algorithm when compared to the expert opinion of a rheumatologist. Particularly when you have those 2 to 3 spondyloarthritis features, you get an HLA-B27 and it's negative. 80% of the patients do in fact do not have inflammatory back pain, but 20% of them were missed and actually do have spondyloarthritis when compared to the expert opinion. And further, if you have greater than 4 spondyloarthritis features, then most of them are diagnosed correctly in having a spondyloarthritis, but 30% of them are diagnosed erroneously. So the algorithm is good, but not perfect. And as I mentioned, this algorithm can be really helpful in diagnosing patients with spondyloarthritis, but at the same time, this is just too complicated to do probably in daily clinical practice and have it actually be utilized in identifying these patients. Further, as I mentioned, in primary care and in the busy clinical setting, it's incredibly complex. You have numerous competing demands for your time, and you just have a very limited time to say yes or no and decide whether to refer or not refer. So perhaps our goal should instead be, instead of diagnosing these patients at an early stage, should just instead be to try to identify suspicious candidates that have inflammatory type back pain. And so we need to devise a systems-based safety net to improve the recognition of these patients that is easy to perform, time neutral, has good sensitivity in identifying case patients, but doesn't identify too many patients to result in over-testing or over-referral, burdening our healthcare system. We have to find that balance. And so there's a few potential solutions out there. Well, number one, we could just increase our understanding of spondyloarthritis. And maybe from that we can just have improved diagnosis. And that's probably one potential solution. However, it's incredibly inefficient because diagnostic error is not unique to spondyloarthritis. The list of diagnostic error for potential presenting complaints and for different diagnoses is just a mile long. So instead, we should really develop like a systems-based approach for how to approach a lot of different conditions. One potential solution is just screening high prevalent populations. We know that patients with IBD, psoriasis, or uveitis are a little prone to having spondyloarthritis. Prevalence rates are all across the map for all these conditions, but the ones that I saw for IBD, spondyloarthritis, somewhere ranges from 18 to 45%, psoriasis around 30%, uveitis greater than 20%, and it goes up to as high as 80% if it's recurrent anterior uveitis. So could we develop algorithms to identify these patients within those clinics? It could be complicated algorithms. They do exist for uveitis and appear to be excellent algorithm. But we could just be as simple as asking the patients in these clinics, do you suffer from chronic low back pain? And did disease start before 45 years old? Because as I said, 95% of patients have back pain before 45 years old. And if the answer is yes, then that merits a referral to a rheumatologist to go through the more complicated diagnostic process with these patients. Another potential solution is just to have more simple referral strategies for identifying these patients. There's been a number of studies that have looked at whether we could just use very single clinical criteria to determine which patients should we just refer to the rheumatologist. All of these studies had the inclusion criteria of patients having chronic low back pain, so greater than 3 months of back pain, and age of onset less than 45 years old. Most of them involved inflammatory back pain as one of the clinical criteria for saying if the patient has those conditions and inflammatory back pain, they should be referred to the rheumatologist. And what you can see for the studies that looked entirely and only at inflammatory back pain, then about 33% of them were ended up with a diagnosis of spondyloarthritis. So put another way, 3 patients referred with inflammatory type back pain, 1 of them will be diagnosed with spondyloarthritis, which is, I think, pretty good. There's been a number of other studies that have looked at whether to refer if the patient has inflammatory type back pain or HLA-B27 or sacroiliitis. And at that point, the rates of the patient having spondyloarthritis improves, perhaps not too surprisingly, since those are helpful distinguishing features of patients with spondyloarthritis. And then it gets to approximately half of the patients that are referred and end up being diagnosed. As a result of these studies, the expert opinion group for the spondyloarthritis in Europe, released these referral guidelines in 2015. And in that, they included the chronic back pain patients for greater than 3 months and age of onset less than 45 years old. And then they said, basically, if the patient has any feature of spondyloarthritis, we feel that these patients have a decent chance of having spondyloarthritis and deserve expert opinion at that point to weigh in and determine whether these patients actually have disease. What should be noted, though, is that we really don't know how good this is going to work in the real-world clinical practice. We don't have those prospective studies out there for that. But if we believe the published literature, based upon just using inflammatory back pain, if a patient has one of these features, we can logically say that about 3 of them being referred for this, one of them will have a diagnosis if they have one of these features. I'm not suggesting that we should check HLA-B27 and sacroiliitis with MRI or X-ray for all patients that have chronic low back pain less than 45 years old. I just don't think that that's resource sustainable within our healthcare system. I think instead we should be checking all of these criteria here. But that brings us back to that original problem. How do we remember all of those different criteria? It doesn't make sense why patients with spondyloarthritis have uveitis or enthesitis. It wouldn't make sense to ask these patients that come in with chronic low back pain about whether they have uveitis or enthesitis. It just doesn't make logical, intuitive sense. So this brings me back to what I think is really the solution to a lot of diagnostic error, and it's the power of checklists. We all know that checklists hold great potential when it have proven their worth when it comes to performing complicated tasks, such as flying a plane, or doing a timeout before a complicated surgery, or before inserting a central line to make sure everything is being done in an evidence-based way. What I would argue, though, is that diagnosis is the most complicated procedure that we have. And as a result, a well-designed checklist could prevent the practitioner from failing to consider potential diagnoses and also providing hints of things to ask about to make your differential diagnosis more robust and more accurate. There's not great evidence behind checklists because there's really no evidence behind any solution to diagnostic error at this point because it's just such a young field. Anecdotally, it's been great for one particular advocate of checklists, John Ellie, is a family medicine physician at the University of Iowa. And he's found that this has been tremendously helpful in considering correct diagnoses. Based upon this checklist kind of model, I made my own differential diagnosis list for back pain, according to how John Ellie does it. And it has the 2 categories, don't miss diagnoses, and then those common diagnoses. Within the don't miss category is the compression fracture, cancer, infection, referred pain for vascular, visceral, cauda equina. And then I also list all those things that you should think about or ask about, such as could the patient be on corticosteroids? Because that has a very high likelihood ratio for compression fracture. Or for infection, do they have a recent infection? Do they have IV drug use, etc.? And then I also have here under the spondyloarthritis category all the referral guidelines and all the things to ask about. And I really believe that this would be a relatively time-neutral approach, especially if we have a well-oiled clinical setting in which perhaps even the medical assistant could be having like a pre-printed out checklist of the things that the patient can check out and just provide that to the physician to ask a few further questions if things stand out. So returning back to the patient here, due to her symptoms of uveitis and inflammatory back pain, she was referred to rheumatology for evaluation. Radiographs were negative, however MRI was positive for sacroiliitis, and therefore diagnosis was made given the post-test probability of greater than 90%. She was started on physical therapy and inflammatory dosing of naproxen, and she had a good response from this, thus she did not need a TNF inhibitor yet. So my overall conclusions for my talk are that the field of spondyloarthritis is undergoing rapid advances in disease understanding right now. We currently have these two pools of patients, the patients with a radiographic disease and the patients with a non-radiographic disease. We don't completely understand the characteristics of the patients with a non-radiographic disease, because this is just a very recent disease expansion of what we understand of as disease. As a result, our understanding is that spondyloarthritis is relatively common and is present roughly equal in men and women, and should be strongly considered in patients with chronic low back pain with disease onset less than 45 years old. What we can also say is that potential solutions out there should be systems-based and should improve the early diagnosis, perhaps through screening of high prevalence populations that have a highly enriched population of spondyloarthritis, where likelihood of patients actually having spondyloarthritis is high, or just very simple referral guidelines. And I really think that the lessons that we've learned from studying these model diseases that have long delay in diagnosis, such as spondyloarthritis, hold great potential in improving our diagnostic error for other diseases as well. I'd like to thank a number of different people. I'd like to thank the Department of Medicine for the past 4 years of excellent training. I cannot imagine a better place to have my training in internal medicine. I'd like to specifically thank Dr. Page for the honor of being able to provide grand rounds, Dr. Vogelman for his excellent clinical and professional mentorship over the last 4 years, Dr. Holland for taking a look at my presentation and helping with the flow and design of it, Dr. McCown for all of his help over the last 2 years in his clinic, where I learned so much, Dr. Bartels and Dr. Hansen for all their research mentorship over the last 2 years, my fellow chief residents, the internal medicine residents, and most importantly, my family. Thank you so much.
Andrew, that was terrific. I'll ask you to call on the audience and please repeat the questions.
So that was excellent. Patients are starting to come in with outside tests of HLA-27, and they're starting to look into diseases, and a lot of them that are getting this done have some family history, probably linear distant of diseases. How do you think that's going to help or hinder us as we go forward?
The question was, patients are often,
Good job.
I've learned over the past 4 years, over the past 4 years have been independently getting HLA-B27 testing or have a family history, and then coming to the general practitioner and saying, what now? How does this help or hinder us? And I think it does both. I think it helps you in that you now have, if the patient actually has disease onset less than 45 years old and actually has HLA-B27 in a family history, then you can say that the probability of disease is moderate, that you actually might have inflammatory type back pain. Where it hinders is that this is incredibly gray, the diagnostic process for this, and that even though you have those objective studies, it doesn't mean that you have disease. They have a likelihood ratio of 9, but that can just bring you from a pre-test probability of 5% to a post-test probability of around 40 or 50% if you don't have any other features. And I think that can be complicated for everybody involved in the diagnostic process to understand that even though the objective studies can be positive, that doesn't mean that you have true disease. That'd be my take on it. Dr. Vogelman?
There might be I love this talk. It's a great talk. And I love the paradigm of all this lead time because we had that with RA, and now we have drugs that might be able to stop destruction. So we intervene earlier. We learn that about this disease, then it will be very important to intervene earlier. We rely on curiosity and memory as doctors. The nursing schools have had checklists for years.
question was whether our current generation may be more susceptible to utilizing checklists in the diagnostic process, more like other health professionals have already been doing, like the nursing school. And I don't know the answer to that question. I think it's a really good question. I think we're starting to have the recognition that in the patient safety movement and in diagnosis, it shouldn't be the heroic act to make a good diagnosis. Instead, we should have just a more reliable approach to diagnosis. And the way through that is through checklists. I think currently we're in information overload when it comes to disease understanding. I'm not even sure how many ICD codes there are for different diagnoses and how many different possible presenting complaints that come to the referring physician. And remembering all the details that I mentioned here is going to be impossible. So I think checklists really are the solution to raising the kind of bar for everything and making a safety net.
And I want to respond to that. I think with the EMR system and us, I think everybody in the world aiming to write notes, if the system-based approach would be that you type in a chief complaint and the system would provide you a checklist for a review system that potentially the patient already filled out in the room and throws in the review systems into your note. That's the way you would probably get buy-in from a checklist and then have the thinking in the diagnosing part afterwards. But that requires, I think, still a lot of development of EMR systems that is not geared towards coding and sort of that approach, but towards, as you pointed out, making the right diagnosis.
Bjorn's comments were about how EMR facilitated decision support, diagnostic support is really the way forward when it comes to checklist formulation. And I completely agree. I just think that that's so many years in the future. And I think is actively being looked at by IBM and Epic right now. I think, though, that before that happens, if we make a priority of checklists, particularly in the medical school stage, when we're learning how to do diagnosis and learning how to do history and physical and learning the entire head-to-toe physical exam, that we just start formulating, and the specialist organizations as well, developing checklists along with the primary care that are really evidence-based and really clinically helpful instead of these long guidelines. So I think there's actually a number of more practical short-term solutions as well, but I agree that the ultimate solution that I think will have the best buy-in will be like an EMR-based integrated.
So with that, I'm afraid we have to close. I want to thank Dr. Vreede and congratulate him on an excellent Grand Rounds.